Hi, everyone. We'll just give it a couple of minutes for others to trickle in, and then we'll get started. Okay, I'm going to make a start on intro. It is my pleasure to introduce Professor Neil Rajan, who is a principal investigator and honorary consultant dermatologist based in Newcastle in England. His basic science research program is coupled with the delivery of early phase clinical trials in rare disease, an exemplar of which is the TRACK study in CYLD cutaneous syndrome, where he was chief investigator. He works with patients with inherited skin tumor syndromes to jointly advance understanding of how skin tumors form with the intent of developing new therapeutic strategies. And he is also the deputy editor of the British Journal of Dermatology. So over to you, Dr. Rajan, Prof. Rajan, sorry.
Monty, Bill, and everyone else, thanks so much for inviting me. And it's a real pleasure to be asked to speak to this forum. Firstly, I wanted to say it's a fantastic opportunity to speak and to listen to global dermatology talks, I think, because there is such a need for forums where we are able to highlight particular bits that I think textbooks fail to do as well as we would like to see, particularly in the scenario of rare diseases. And in terms of the population in general, we think about 1 in 17 people has a rare disease if you look at rare diseases collectively. And unfortunately, due to their intrinsic nature, sometimes they're not given the sort of spotlight and focus we would like to offer them. And so over the next sort of 40 minutes or so, I hope to highlight certain rare diseases that are likely to present to dermatologists with a focus on inherited skin tumors, which is an area of interest that I work in. So I'm just going to advance the slides. I work at Newcastle University, as you've heard, and my area of interest is inherited skin tumor syndromes. And perhaps it's important to maybe point out that I perhaps didn't start my career thinking that, this is definitely where I want to go. As ever in clinical dermatology, you are faced with patients that you can help and therapies you can give and that sort of satisfaction. And also the sense of sometimes that you could do more for a patient and that there's nothing left in the therapeutic cupboard. And so I, would always champion the case that when you are in that position to think about research, to advance that gap, to make an improvement in terms of the unmet need for patients, because unless we keep pushing as clinicians with the insights that we bring for those areas where we don't have therapies, we won't ever make advances. So I hope to share a little bit about my experience in that sort of way in a moment. I have no relevant conflicts of interest to declare in relation to this talk. And in terms of an outline, what I wanted to focus on today were tumor suppressor genes and kind of highlight this with a particular exemplar, and also to speak a little bit about how some of these conditions can present in mosaic ways and when to think about them. I want to maybe put across as learning outcomes the two-hit hypothesis, and I'll explain that in a moment, and how this is a recurrent feature in different tissue and cells in different tissues that we've slowly uncovered with research over time. To realize that these things can run in families, and the importance of taking a family history, the importance of recognizing how different tumors can present in different members of a family, and as dermatologists, obviously, to detect skin signs that can make the consultation also focus beyond the skin, to think about how the other tissues in a particular patient might be at risk, the need to know about the genetic status in such patients, and to think about screening. And sometimes we're in a position to offer very low-cost therapies that can reduce the cancer burden in such patients. So I think those are the aims over the next sort of 30, 40 minutes. I wanted to start with this image because in terms of people who have really, brought the concept of tumor suppressor genes into the spotlight. I mean, Angelina Jolie's narrative when she was found to carry variants in BRCA2 was perhaps, huge in terms of raising awareness about genetics and cancer. And I think it's, it was a moment when people sat up and suddenly thought more around, inheriting a highly penetrant variant in your DNA could increase your risk of cancer. But obviously, that was one important person for doing that. I think it would be remiss to have this talk without highlighting the great work of Alfred Knudsen, who initially, made the observation in retinoblastoma and really using mathematics and the distributions of these tumors in affected individuals and numbers kind of arrived at this hypothesis that in many of these patients there must be in every cell a scenario where one of the many pieces of DNA that we all carry is affected and maybe may not be functioning, but it's only when the remaining copy of that other allele of DNA is inactivated that we see a phenotype in the patient. And so another perhaps poster person for the two-hit hypothesis. And so to speak a bit about what that involves, Knudsen kind of hypothesized that in sporadic cancer, we have a scenario where you have a copy of an allele from or a piece of DNA from your, say, dad, and then you have got a copy from your mom as well, and maybe over if on one of these alleles there was a tumor suppressor gene, over a period of time as cells divide and we age and the rest, we lose the working function of one copy, often by genetic variation such as mutation, and then over a period of time, if the remaining copy was to be affected, indicated in red here, that would lead to tumors forming. And in the context of inherited tumor syndromes, the key difference is that one of those changes has already happened from birth. And there is this sense that if you're already halfway there, you might hit this point in time when the remaining copy is inactivated sooner. And really, the scenario that would raise this in the clinic is if a person has perhaps tumors or cancers before their time, if they've got more than one of them, or they've got cancers of a particular type, something sometimes that's uncommon. And in dermatology, we see a range of phenotypes, and we sometimes think about when these pieces of DNA may come into effect. And I'm just sharing on my screen at the moment a number of different images of patients that I've looked after who've presented in my clinics. And these phenotypes can sometimes be quite subtle. The phenotypes can be sometimes quite overt. Sometimes we don't think of all the pieces of DNA that may be linked to them. And it's important to be aware that there are increasingly genes that can be tested for in these patients. And so to, maybe not be so coy about it, there are certain conditions listed here, which we'll cover in a moment. So this isn't meant to be like a shopping list of conditions and related genes, but I really make the point here that there are increasingly known genetic causes for a whole range of different tumor syndromes that can manifest with a skin phenotype, and each has a particular, sometimes tropism, to other tissues in the body that may also be affected, and these are gene specific. The scenario which I covered earlier is one where the earlier pattern of presentation may involve low-grade, often benign tumors, which is why sometimes these patients are managed in from a cutaneous perspective, but and then sometimes discharged from care. But there is the scenario where when multiple skin tumors present, there is the need to think about an underlying predisposition. And I like this model of the skin that I got a while ago, where you see the rich kind of range of structures in human skin. And if you think about it, to maintain such a diverse set of mini organs, if you like, in this tissue that's sometimes just limited, described in a slightly limited way as a barrier, you start to become aware that there must be lots of different stem cell compartments that sort of maintain and renew these tissues. And what we recognize is that in terms of what the pathologists have seen over the years, in terms of what the clinician has seen over a period of time, we can link certain skin tumors that arise to certain structures, simply by the appearance of the pathologist and sometimes by the cytokeratin profile or other markers that the cells may express that make people think, these tumors are likely to arise from these tissues. And so I'm going to speak a bit about a hair follicle tumor syndrome, silk cutaneous syndrome, and I want to speak a little bit around the phenotype initially, and then maybe share a bit more about the genetics. So the condition is one where there are two key tumors seen in the patient. Cylindroma is the sort of archetypal tumor, and there is also this other entity that's related, known as spiroadenoma. Cylindroma are often pink large nodules in the scalp with overlying arborizing vessels, a bit like we would recognize in BCC. And spiroadenoma classically are painful blue nodules and are one of the painful tumors that we all learn about as dermatologists. These tumors can grow in up or down. They can be endophytic or exophytic, if you like. And I highlight this to the surgeons in the audience, really, that may sometimes palpate a tumor. And really, when you're going in to remove it, you just need to be aware there's a little bit of an iceberg sometimes under that top layer of skin. And in addition to those hair follicle related tumors, patients in these families can get other hair follicle related tumors at different sites. So interestingly, on the skin around the eyebrows, the nose, and the upper lips, you can get small trichoepitheliomas, which are very typical. And also you might see an excess of milia in some of these patients too. And we've had families where sometimes patients who don't have any tumors are simply found to be gene carriers on the basis that they have an excess of milia later in life. And sometimes this can be helpful to help decide if someone may be carrying such a variant in such a family. And indeed, this patient here had a son who just had a few milia, and he had also inherited the change in CYLD that could be passed on. And so when I first started, I worked with a Mohs surgeon called James Langtree and a professor in genetics, John Byrne, and a further professor, Alison Trainer. And we were really interested in sort of capturing where these hair follicle tumors turned up in patients across two large families that were based in and around Newcastle. And I think what was striking is that we've already said it's a hair follicle tumor syndrome, but across men and women, we found that women had a greater burden of disease. And we also found that there were tumors beyond the scalp, and interestingly at sun-protected sites, such as pubic skin or axillary skin. And we found that really about up to 40% of these patients had pubic tumors. And so as someone that was interested in skin genetics, there was an opportunity to try to understand what were the processes that, drove the loss of the second hit, for example, the loss of the second allele by a second hit at sun-protected sites, because the existing paradigms always told us about UV. And so, there were opportunities in this piece of work to try to first lay out the phenotype, but then to use whole genome sequencing of tumors from, say, sun-exposed and sun-protected sites and look for signatures that could teach us around how the underlying mutation might have happened or the second hit. It's important to realize in these patients, there is a vulval phenotype, and I worked with a colleague of mine, Dr. Dubois, who's now a consultant dermatologist in Newcastle, and we wrote this small paper in JAMA Derm a while ago, really highlighting the fact that a proportion of our cohort really had these pubic tumors, which could be very painful and could cause sexual dysfunction. I think if you're ever doing a clinic with a patient with this genetic condition, it's important to ask in a sensitive way about this, because some of my patients really only brought this up on the third or fourth consultation, and it was very easy to excise painful tumors and really improve their quality of life. Also, some of these patients will develop tumors at other predisposed sites, such as the conchal bowl, and the tumors at this location can effectively end up occluding the external auditory meatus. And so if you are looking after a patient with silk cutaneous syndrome, check these sites, because you have the opportunity to intervene early and maintain the patency and function of these patients. And sometimes, again, patients almost feel like, oh, it's just a small thing and I won't need to do very much. But if you have an opportunity to nip these things in the bud, then certainly do. And the reason I say that is because these tumors progressively grow over time. And I think for many of us, if we were told, you've got a benign tumor in your skin by a medic, and we could just leave that, most of us would accept that to an extent if these were skin lesions that were not changing over time. But these hair follicle tumors have an ability to progressively grow. And for one of my patients who had her scalp removed at the age of 50, I was removing tumors on her torso and elsewhere. And after a period, she shared this photo of me when she was 21. And she said, look, I haven't always worn a wig. This is what I looked like when I was 21. And I've seen her at this stage in her life when she's had, multiple scalp tumors. And this was in her mid-50s. She was starting to undergo surgery to remove some of these to maintain tumor burden, and ultimately had her complete scalp removed, which is the outcome in 1 in 4 patients who have this in some of the studies we've done. We know that if we look at CT detectable tumors, so tumors that are about 1 centimeter in size, we've had data from some of our patients where we've been tracking them over time for other reasons. And what we find is, across about, I think, 32 tumors in this piece of work, that the majority of tumors grow. Only 2 out of this group that was studied actually stayed the same or grew smaller. And really, year on year, there's between a 5 to 10% increase in the longest dimension of these tumors. And so if tumors are symptomatic or there's opportunity to intervene early, in some situations, this may be a good idea. It's also important to recognize that as we look at this beyond the families that were, say, initially described in Europe and in the northeast of England, that SILD pathogenic variants have now been reported almost from every continent on the planet. And I think what's really interesting is that sometimes the same pathogenic variants in the gene have been reported in families that live in, say, the northeast of England, as well as, say, in parts of Europe, if there's a hotspot. But across these different sites, geographically, depending on the ancestral heritage of the patients, we've seen scalp tumors, for example, or different amounts of severity. But what's interesting is if you look at patients, say, from Africa or from Southeast Asia or from other parts of the world, like Japan, we recognize that the phenotype I've shared of scalp tumors before is hardly ever seen there. However, facial tumors can be, really significant and severe. So when the gene was first found, this was before my time, and so this is John Byrne and Alan Ashworth, and they were key in the late 90s when the Human Genome Project was, really taking off, to get DNA from these multi-generational pedigrees. And they basically found 2 pathogenic variants that were sort of, 9 base pairs apart that helped solve 2 of the largest families with this particular condition. And then with Mike Stratton, a short while later, they basically located the gene across a whole cohort of about 14 families, I believe, at the time, and really identified exactly what was driving this condition. And the interesting thing is the gene encodes a ubiquitin hydrolase enzyme. And very briefly, this is an enzyme that's important in post-translational modifications, where proteins in the cell that have tags, which are made of ubiquitin molecules, can be influenced, if you like, by enzymes like this, such that if you remove or add such tags, you can alter cell signaling and impact on cell survival pathways. And for the gene SILD, the scenario was one where the majority of the patient's pathogenic variants clustered to the catalytic residues in the latter exons of the gene and frequently result in truncation. And so we think the frequent scenario of truncating mutations is an important aspect of the development of this condition. From a patient perspective, what we were interested to see was that this helped seal this 3 different OMIM categories and link them really convincingly as all linked to a single gene. And up till this point, pathologists had noted that in patients with Bruch-Spiegler syndrome and MFT and familial cylindromatosis, one thing that was common across all of them was the fact that you would get cylindromas on the scalp, as well as sometimes other hair follicle tumors at these different sites. And so there's always a suspicion that they were linked conditions. In addition, across different generations of a family, what was interesting was if you looked across, say, a 7-generation pedigree, you would get all 3 patterns sort of playing out in different parts of the family tree. And so this comes back to what we were saying earlier around how the genetic background is really key in terms of the presentation. But also it emphasized that, giving a member of a family a diagnosis of, say, Brooks-Spiegler syndrome wasn't so helpful if, say, another part of the family had been given a different diagnosis. And so in line with Leslie Beisecker's paper that came out in the American Journal of Human Genetics a few years ago, we've been always keen on a dyadic naming, of conditions like this, where we link the gene and maybe an aspect of its phenotype, because the existing labels are not helpful prognostically. And to highlight how the same gene can cause a different pattern in different parts of the world just by virtue of genetic background, this is a family that I've looked after in collaboration with colleagues in Hungary. And this is Nicoleta Nuge in the top right corner, who basically was involved in getting DNA from all these members of a Hungarian, Romanian family. And this was something that I was very interested in, because we had a family in Newcastle with exactly the same single letter out of the 3 billion letters that was apparently altered. But in the Newcastle family, the phenotype was very, very mild. And so we, in addition to seeing what we see in terms of patterns of presentation within a family, we also see variations between families carrying the same change. So in summary, if you are wearing a genetic counseling hat in a scenario where you're looking after one of these patients, a positive test is helpful. And we get a positive test with patients with a scalp cylindroma about 75 to 80% of the time, because downstream from that patient, their children and their children's children can use this information to help decide when they're planning for a family. And our experience has been one where having a negative test in a potentially affected person who's wanting to start a family has been really useful, because they know that they're not at risk of transmitting the condition. Where we're lacking is that currently the positive tests are less helpful, in that we know someone that's very young is possibly going to get the condition, but we can't say anything about the severity. And so there is still work to be done. So I guess this isn't something that's unique to cutaneous syndrome. We recognize in the clinic, sometimes you get unusual scenarios. Here we've got a patient, with a apparently keratinocytic nevus, where there have been multiple SECs that have been developing, and then otherwise slightly, warty keratinocytic looking skin. And this is work that Dr. Dubois helped, highlight, where there was unilateral SECs. We've had other patients where we found that on one side of the body, they get a disproportionate number of melanomas, for example, and work with Veronica Kinsler and Manza Polapathu and Siobhan Mathia really highlighted how in some of these patients, we are now able to demonstrate key genes that are important in melanoma development that are sort of affected with 2 hits, but just on a section of the body. And this is another patient that we've worked with the group at Great Ormond Street with, where we've got a patient who's got lots of nevi on one leg, and the other leg, it may not be so apparent on this slide, hardly any nevi at all. Now, the leg with lots of nevi basically carried a MAP2K1 pathogenic variant in the skin, and this patient has now developed 5 melanomas just on one leg and none on the other. And so I put these things to you because not just in rare tumors, but also in cancers that we see, on a more day-to-day basis, if you see a unilateral presentation or a burden, then think about mosaicism. So in the context of cutaneous syndrome, I was interested in looking at the genetics around this, because it was almost like lightning striking twice, right? Because often when you have a single cylindroma, that doesn't happen that uncommonly. And some of, the early work from the archives that were done on the veteran studies really highlighted that sporadic cylindromas and spiroadenomas were quite common in those cohorts. But when you get 2 tumors near each other, that's when you start to perhaps think about mosaicism. And obviously over the last 15 years, we've had the tools to, tease that out. And so in our cohort in Newcastle, when I first started looking at these families, I was aware that there was no genetic testing, and so helped set this up through our National Health Service, such that patients anywhere would get the opportunity to get their DNA tested. And I remember when we first set this up, we were told, oh, you won't get anything more than the 2 or 3 families you already have. But then over the 5-year period, we had 100 referrals, and we found 75 new pathogenic variants across our country, and we've got a proportion that are still unsolved. And so across many of these patients, we were then interested in trying to figure out whether mosaicism may be a thing. And so in patients that were not known to demonstrate the mutation, we did some work with deep sequencing. And what was interesting here was we used a strategy that my previous PhD student, Dr. Arifan Bevrani, developed, which was a long-range PCR strategy that looked at changes across the whole SIL gene, both in introns and exons. And what was interesting was that when we looked at some of these scenarios where you had two of these tumors turning up, you could demonstrate in some of these patients that when you did like really deep coverage of the gene, so we had more than, I think in this study, 1,000 or 2,000 reads covering every coding base and every non-coding base, really, we found that the tumors had the same pathogenic variant, but interestingly, in apparently normal skin in between, there were it wasn't completely normal. We found evidence of that pathogenic variant, but just at a much lower level. And finally, in other tissues like blood, with the same coverage, we didn't find that at all. And so in some of these patients, when you get more than one tumor turning up in the skin, they may just have got a bit of their skin, a bit like in the melanomas and the SECs that were unilateral I showed you earlier, where this variant is present. And then in some of our patients, once we did this, we also went back to the original Sanger trace where we were told, oh, that was negative. But interestingly, what we could see on NGS, with the benefit of hindsight, we could see a tiny hint to support the fact that, there was also mosaicism in the blood, which we backed up with NGS. And then I've talked about unilateral presentations, but sometimes you will see, bilateral presentations, which may not be obviously clustered. And I think the challenge here is that, it's only quite late in the game when you start to see these clusters presenting. Early on, it might not be really, apparent. And in this particular patient, we had this very interesting scenario where we were sequencing tumors using this long-range PCR strategy, and we found that each tumor carried its own private mutation. And this was really interesting because we couldn't initially make sense of this. And then we went down the route of doing arrays on the patient's blood to look for if the patient had a deletion, and those were reported as normal initially. And then we did an array on the tumor, and we did it on 2 or 3 tumors. And we found that there was this 5.5 megabase deletion that involved a number of genes, including SILD. And really what was happening in the tumors in the scalp was every time this second hit happened, it was really just taking out, the one copy in those cells, and then a tumor would form. And this was quite interesting because this patient had a childhood of a unilateral kidney from birth, and also an unusual gestalt, and also other like subtle features which everyone couldn't quite tie together. And so off the back of this finding in the parent, we offered the germline test of the array, and we found that this child had inherited that 5.5 megabase deletion. Interestingly, the child's grown up, is 30 now, and she's not developed a single tumor yet. So to bring some of that together, we know that in most of the population, you'll have this scenario where you've got 2 working copies indicated here in blue, and the likelihood of developing a single cylindroma is really, really quite uncommon. And this is the state in most normal or sporadic patients. But then in patients where they've got 1 working copy and 1 abnormal copy, shown here with the red and the blue, the second hit happens and you can get tumors in the patterns I've shown you right at the beginning of the talk. But in some of those families, you will get patients either developing tumors that are clustered in addition to the more broad spread. And here you might have a second hit that's happened prenatally. And then finally, you can have some patients where there's no family history. And in these individuals, you can sometimes get mosaicism just in the skin, but sometimes in the skin and in the blood as well. So in summary, when you see clusters or linear arrangements of tumors, think about mosaicism. Consider this when germline testing is negative and you think, it's really quite unlikely that this patient could be having all these sporadic single tumors. If you want to, pursue genetic testing, the easiest route is to sample at least 2 tumors and get a bit of DNA taken and look for SILD. And typically you'll find the same change in SILD across both of those tumors. And if you know about that variant, then you can use that to guide genetic testing in the children of a mosaic parent. So I'll just stop with the first set of learning outcomes. these are the sort of take-homes. Tumor suppressor genes in the skin can play out with a range of phenotypes, and the two-hit hypothesis holds both in the sense of what happens in patients who've got a germline heterozygous pathogenic variant, as well as patients with a mosaic presentation. Recognizing a dominant pattern of inheritance in a family with tumors or cancer, is typically what you would see in many of these conditions. And if you see unilateral presentations, think of mosaicism. So building on what I've just shared around an exemplary skin inherited tumor syndrome, I'll speak more broadly about other genetic conditions where you might see skin tumors as well as cancers in the skin or in other tissues. And so, as I've hinted already, there are a range of phenotypes, a range of patterns of presentation, and I'm keen to just focus on key concepts and some clinical examples, and also have the opportunity to speak a bit about diagnosis and management. And again, this list of genes, and I'm just flashing this up very briefly because it's important to have this in mind, because depending on the types of pieces of DNA that are affected, one might need to think about either tumors or cancers in other tissues. And in terms of how uncommon these things are, sometimes this is a slight barrier, and I just wanted to move this forward because it can be difficult in terms of sometimes conceptualizing large numbers. So for some of the conditions that we'll speak about today, it can affect about 1 in 90,000 people. And for the football fans out there, in the UK, we've got Wembley Stadium, which takes about 90,000 people, and this is on par with having one person at such a match being affected. In some scenarios, it's even more rare than that. It's 1 in a quarter million, and this is a Paul McCartney concert at El Zocalo, which kind of captures the scale of what we're talking about. And really, across all of these different numbers, there is sometimes a sense that, oh, I'll never see such a patient. But the reality is, if you've started to see patients with multiple skin tumors in your clinic, it's important to think that you could be in one of those moments where, despite being a rare event, it is a rare event that's happening. And, you have the opportunity to influence a number of things when you can think about genetic testing. So I've woven in an interactive section to this. And so in the chat, there is the opportunity to respond if you like, but don't feel pressured to. And what I'd like to do is really highlight a few cases to, get you thinking about the different genes. And this is when those red genes I showed you earlier are helpful. And so those of you with, photographic kind of memory will benefit from those slides. And so this is a 28-year-old man who's presented with multiple skin tumors, and this is the pattern on his chest. And I think what is apparent are that there are papules, largely skin colored, but some have become inflamed and have had excoriations. And I think the point I'm trying to make at this stage is, as a dermatologist, there is no shame in not knowing what tumor this is just by looking at it. And simply because the majority of the tumors that I've shown you will just be skin colored and won't have, very striking and obvious features in isolation that you can pick up by putting a dermatoscope on and calling them out. And so the credit almost always goes to the pathologists, who can look down the microscope and there really see, defining patterns. And so, when you are presented with this, the real take home is, there are lots of, skin bumps, so they don't particularly look dangerous, but the fact that there are so many should make you think about it. And in this particular condition, this patient also has got, skin tags on that sort of skyline view. And as I've hinted at, dermoscopically, there isn't very much. Really what I'm pointing to here with these red arrows are sort of plugged follicles in the center of some of these papules. And so if at any point people feel like they want to respond in the chat with what they think a condition is, then please go ahead, and that would be great. But even if you don't, that's fine. To go further, some of these patients sometimes can present with a chest X-ray like this. And for the person that's not, regularly reviewing chest X-rays, I've helpfully put a red arrow on this side to highlight the pneumothorax that's on this side. And here on CT, you can also see, in addition to that, the fact that there are cysts in different areas, these sort of loculated areas on the CT. And for the budding dermpaths and the established dermpaths, these are the sort of histological features, the sort of bat wing type projections, or this sort of central region with overlying thinning and displacement of follicles to the edges. And finally, a tumor here from an internal tissue, and you may already know what I'm highlighting if I've highlighted an internal cancer, pneumothoraces, and skin tumors. And so this is indeed Birt-Hogg-Dubé syndrome, where there is a triad of fibrofolliculomas, trichodiscomas, and skin tags. Hornstein-Nickerberg for the aficionados in the audience, and is another eponymous set. And we think about 90% of patients have skin lesions later in life. It's thought to be fairly rare. About 400 families have been described, and there is this increased risk of pneumothorax and also the presentation of bilateral renal tumors of some of these types should raise the suspicion. If we think about screening in different parts of the world, there are different protocols. Here in the UK, we offer an MRI as a baseline and then have an ultrasound screen each year, typically after the age of 20. If a lesion is found on screening, there is the 3 centimeter rule for renal tumors, and they can be tracked given the type of tumor they are up to that point. And then at that stage, a decision may need to be made around whether or not surgery should be pursued. So moving on, this is a different condition where this patient has got clusters of tumors on one leg. So almost certainly we need to be thinking about mosaicism, but there are also isolated lesions on the other leg and on the rest of this patient's body. And this is a close-up. These are painful in the cold. And this is the histology, where the epidermis overlying the tumor is, not very exciting, but, really it's down in the dermis where these smooth muscle bundles are seen. And a close-up. And this is HLRCC with cutaneous leiomyomas. Important to always take a history in female patients about uterine symptoms, because uterine leiomyomas are a frequent feature and can cause a lot of morbidity. And increasingly, work from Manchester in England, from Gareth Evans and Emma Woodward, have highlighted that HLRCC renal cancer in these patients can happen at a relatively young age. And increasingly, the guidance is that younger and younger children need to start their screening to help pick up cases of renal cancer. So we think about 76% of patients have skin lesions. There is an increased risk of renal cancer, and in this scenario, it's a different subtype that's slightly more aggressive. Typically, they can present at around a mean of 44 years of age onwards, but there are cases happening in children at the age of 12, for example. And so the guidance in different parts of the world is different. In the UK, we say MRI with contrast from the age of 10. In the US, there are some centers that do this from the age of 8. And so just in the interest of time, I'll keep going. The next condition to think about is one where there's a history of facial papules and breast cancer, and that might also come together with this presentation of acral keratoses. And if you're thinking of breast cancer, facial papules, and acral keratoses, some of you may already know what this is. But for completeness, if you asked the patient to open their mouth, you may see fibromas on the tongue and around the opening of the mouth. And then you might see changes like this in the scalp, which I, very confidently diagnosed as, a case of a cylindroma in the scalp of this patient. But this was a sclerosing collagenoma, which may have helped some of you clinch the condition we're talking about. And in addition to that, these patients can get cafe au lait macules and lipomas. So this is a P10-related phenotype, and in this case, Cowden syndrome. And it's important to think about breast and thyroid cancer as well as endometrial cancer. Unlike some of the other genes I've highlighted earlier, where there are, say, leiomyomas or cylindromas, these patients get a whole range of different types of benign skin changes. And, it suggested that P10 plays a slightly different role to some of the other slightly more narrow skin presentations that we just heard about. And in these patients, we have to think about breast screening, annual ultrasounds of the thyroid, colonoscopies, and renal imaging. And typically this starts, 5 to 10 years earlier than the youngest case in the family. But it also has to be recognized that exceptionally, you can get scenarios where very young people get thyroid cancer. So for the next case, I'll speak about this pattern, a pattern of multiple basal cell carcinomas. Here shown in black, the treated ones, and in white, the problematic ones from this patient in Newcastle. You can see this sort of change on the palms of patients with this genetic condition. And if there is a history of if there's a jaw X-ray, then there is this presentation of cysts within the lower jaw typically. Patients can also have skeletal changes such as bifid ribs, and I think they never show very well on chest X-rays. And so I was keen to share this image, which I found, which kind of shows a bifid rib that's schematically described as well as drawn out. And if you see this, you need to be thinking about nevoid basal cell carcinoma syndrome. And we think that this is driven by changes in PTCH or patch1. And the two commonest patterns described in the paper by Kimonis are BCCs or odontogenic keratocysts, typically present by the age of 21. There are also some families where medulloblastoma may be a feature. And if this were to present in families with nevoid basal cell carcinoma syndrome, the mean age is at the age of 2. And so these young children in these families can get screened if they are variant carriers. Now, what is interesting is in the last sort of 10 to 15 years, there's been a second gene for NBCCS, which is SUFU or suppressor fused. And patients with this variant perhaps have a slightly increased burden of medulloblastoma. And this is a pedigree that Seshi Manam in the image found, where we were looking after this gentleman who was a proband. And initially we had this story of, different members being affected in the family. And we found the variant in Sufu and then went back and Seshi did a bit more asking around the family history. And it became apparent that the family had lost a very young child to a brain tumor when they're very young, and they didn't really speak about it so much. And so we weren't aware of that until we came back with the variant, if we're honest in this case. And so to highlight some of the different patterns, because this has only been described in a fairly small number of families where you've got the skin phenotype, these are two pedigrees from other centers where there are infundibular cystic BCCs and history of sometimes meningiomas. This is the Newcastle family that I was highlighting. And interestingly, in this family, when we first started sharing some of these images, the question was, did this patient have silk-cutaneous syndrome? We checked still, that was normal. But then the history of medulloblastomas only came out latterly, and that kind of, made the whole phenotype make sense. This is an image of an infundibular cystic BCC, which is slightly different from the more common variants you might see. And these tumors can turn up at pubic skin, which is where this patient had this particular lesion. And so the slight differences are the lack of jaw cysts in these patients, later onset of BCCs, diverse patterns of hair follicle-derived tumors. And so think about that if you don't get, say, one pattern of hair follicle tumors on the skin around the face and nose in these patients. I think I might speak a bit about this, and we'll hopefully be nearly on time, and then we can take some questions. So this is a pattern with skin cysts and bowel polyps, and so images that dermatologists don't normally see. And that, sort of combination should make you think about Gardner's or familial adenomatosis polyposis, which is thought to affect around this many patients. The key thing is that you may get cysts and puncta may be present. There may not be so many, and this work by Barbara Leopard was key in sort of capturing this phenotype. In addition to these changes in the skin, you can get fibromas of the skin and desmoid fibromas in the mesentery. And so some of these other tumors should make you think about Gardner's. Not to be confused with pilar cysts. And if you've been looking at some of the tumors of cylindromas earlier, you'll see that unlike cylindromas in the scalp, these tumors do not have thinning of the overlying skin, the hair is intact. And so these are sort of features that would make you think more of pilar cysts than cylindromas or epidermoid cysts. And again, this other piece of work by Barbara Leopard back in the 70s really highlighted that these cysts lack a punctum. There's a strong focus on the scalp, and the site is of these tumors is not exclusively the scalp. You can also get some on the body, and really it's the histology that is diagnostic that these are trichodermal cysts. And latterly, there's been some work to show that this variant PLCD1 is the gene that might be behind this. And so the histology is key in this scenario here, an epidermoid cyst, and here a trichodermal cyst. One more case perhaps, highlighting colorectal cancer and skin papules. So again, a fairly banal sort of clinical appearance, but on the histology, you'll see that there are some vacuolated cells here. And this is Lynch/Muir-Torre syndrome. And in the UK, we think about 3% of all colorectal cancer cases are due to an underlying diagnosis of Lynch syndrome. And the 4 key genes are thought to be altered in about 1 in 300 people. And so we are in this country in a position where every new bowel cancer diagnosis ends up getting a test for mismatch repair protein expression on the sample. And more recently, this has been extended to include endometrial cancers. And there is an idea that across the other tumors linked to Lynch syndrome, patients presenting with these will get such screening eventually, and also some germline testing where the screening is indicative. And the reason detecting this is helpful is we are now in a position where we know that aspirin can reduce the tumor burden. This is an image of John Byrne, who I highlighted earlier in the talk in his youth, and here latterly having moved on and upwards from only being in spaces where he was finding new genes to now making differences in patients' lives by intervening with aspirin and reducing bowel cancer. And so he leads the cancer prevention program for Lynch syndrome and has done multinational studies that have shown that aspirin does reduce bowel cancer in these patients. And currently there is work to look at the optimum dose of aspirin. And this is the group that do that, and the colleagues in Newcastle that drive that work. So I'm going to close now by maybe recapping. I've shown you a lot of images, a lot of linked conditions. I want to really highlight that, as varied as some of that may be, a full skin exam in clinic is the key thing to think about. But then that coupled together with a family history is really important. Sometimes the order in which these things happen are never the order in which we like in clinic. So the skin biopsy sometimes comes after the skin exam, and then we see the patients in follow-up and do this. And I'll hold my hand up and say, like everyone else, this is the reality. Gene testing, if you can access that, can be really helpful. And depending on the genotype, then there is the need to think about cancer screening and then monitor both in the skin and in other tissues. The key take home is, when you see more than one tumor, think about underlying genetic conditions. You can potentially intervene, and the hope is going forward, the understanding of the mechanisms based on the genetics that drive these tumors can allow us to come up with newer treatments that may not be surgical, as we've seen in nevoid basal cell carcinoma syndrome, where some of those patients can now take a smooth end inhibitor and reduce the amount of surgery they need. I'd like to highlight different members in my group, or past members in my group, that have written around this in a couple of papers. There are lots of other good ones out there too, but some places to go to for further reading. And with that, I'll finish with an image of Newcastle. It always looks like this. And so happy to take any questions. Thanks very much.
Thank you so much, Professor Rajan, for that really fascinating talk and highlighting all these rare skin tumor syndromes, some of which clearly cause such huge disease burden from the photos that you showed. We're opening to questions now, but I also, if I may, I just wanted to start by something that you just touched on at the end as well. Do you think there's scope in the future to have potential systemic therapies for these skin tumor syndromes, other than just kind of monitoring and surgical debulking, which you already showed? And if so, have we gotten anywhere with that yet?
No, sure. And I think, the exemplar that gives me hope for that is, what's happened in nevoid basal cell carcinoma syndrome. And, I think what's amazing in that sort of work is this space where people were initially trying to understand the function of the hedgehog signaling pathway, studying Drosophila and very fundamental biological systems, and then moving from that through to developing small molecules, which are now in the clinic. And so I think in patients who are at risk of getting a lot of skin tumors, a bit like in nevoid basal cell carcinoma syndrome, I think, we could possibly, if we understand the mechanism, have trials that will start to intervene and hopefully aim to reduce tumor burden there. I also, want to say that for that to work, we need to be better at being able to prognosticate which patients will do badly and which ones won't, because currently, that's the other bit that we really need to start to figure out. What is it that makes some patients get so few and some patients get so many in, say, cutaneous syndrome? Why are women more severely affected than men? There are a number of pieces towards that set of steps that we want to try to better figure out. But having worked with patient groups, the real ask is to develop not just a systemic, but a topical intervention, because many of these patients are, to be honest, quite tired of seeing dermatologists and plastic surgeons that are offering different interventions to prune things back. And they would love to have, a topical intervention at home, which may, inhibit their pathway of interest at a very early stage. And so potentially that's something which, is quite interesting.
Yeah. And I think kind of linked to that, Dr. Damsky asks, are there drugs that enhance ubiquitination that could be used, or is it safe? Or more generally, do you have any thoughts on medical therapies that are worth evaluating? I guess you've mentioned the
Sure.
topical.
So that's a great question. And I mean, the thing about ubiquitination is it's such a broad process, and so it's used by so many of our cells, our immune system, and across the range of compartments in humans. The idea of like interfering with like a process like that doesn't seem intrinsically like a good idea. But to come back to the fact that these cells in the skin and in the hair follicle in particular have this disproportionate effect of a gene that's altered in every cell, really, on one copy in these patients, right? So what we think is possibly a way to, target this failure or the lack of an ability to remove ubiquitin tags because of these mutations is really the key signaling pathways that are affected. And so what we do know is that when these tumors are studied at the transcriptomic level, NF-kappa B signaling is deregulated and Wnt signaling is deregulated. And some of the work we've been trying to do in my group is really to look at developing models where we can start to interfere with these pathways with inhibitors. And I think the particular attraction in dermatology is you've got this ability to take samples from these patients and study and look for weaknesses that can be targeted, but then you can go back from that to that same tissue and deliver locally in the skin. And so where other people that work in tumor biology sometimes are then faced with the challenges of targeting the tissue, we can physically put the intervention on where the problem is going to be. And so there is I think a route for traction where we don't target ubiquitination per se, but actually think about how we can interfere with the signaling pathways. Another strand that could be really interesting is this idea of using therapies that actually read through the stop mutations, if you like, or the stop inducing mutations in the patient's tumors. And so there is increasingly an interest in a number of different conditions where the genetic change, results in a premature stop signal in the reading of the transcript. And if you can use antibiotics like gentamicin that effectively tell the cell's machinery to ignore that stop sign and read through, you get functioning protein that you wouldn't have otherwise. And what's really interesting as a possibility is to restore ubiquitination or in those cells, you may be able to topically apply read-through agents. And that's an emerging area in genetics that's not just for skin tumors. And in fact, groups in Israel have highlighted in some types of monolethrics, for example, patients who don't have hair can have read-through agents, and then they can start to see hair grow again. So I think there are a number of strategies that dermatologists and skin researchers have that other researchers can't employ. And that may be to restore ubiquitination by this topical targeting or systemic targeting of read-through, or interfering with pathways that ubiquitination is not able to handle anymore because of these variants.
Thank you. And we've got another question. Does the specific SIL mutation matter in terms of penetrance and severity of the phenotype?
A great question. And so what we know is that you can have all those different patterns within a family and all those different patterns across families, all carrying the same single change. And I think this is where it comes back to perhaps what I see is a limitation of how genetics has been sold, particularly in the context of monogenic diseases, where we have this story that, okay, this one change in your DNA is the reason why you've got this condition, but we don't really speak about, the other 3 billion letters in our code, right? And then I think my hope is as our knowledge becomes more complete, we'll become better at, prognosticating, because currently you can get variations in severity, in penetrance, and I've touched on the fact that gender seems to make a difference here in terms of males versus females.
Also interesting that you mentioned, I think in one of your slides, that females had more hair follicle tumors,
right?
Which to me was interesting because, like, generally speaking, males tend to have a greater burden of hair.
Right? Yeah.
So yeah, I just thought that was really interesting.
No, absolutely. And I mean, we've been interested in how androgens might drive or protect against tumor formation. And there is a particular transcription factor, which is MYB, which we know is overexpressed in these tumors. And part of what might account for this is the fact that in terms of expression of this particular protein, that's impacted upon by the translation of the messenger RNA. And to elongate the MYB transcript, if you like, there is a particular step that is very dependent on the estrogen receptor. And we think that may be, one thing to point the finger at. But the reality is that we don't really know or are able to explain as to, why these tumors appear after puberty, or at least after adrenarche, why they are predisposed to sites where you might have secondary sexual hair. So we think androgens are, playing a role. It's just we don't fully understand it yet. But this is where more funding and more research would be great.
Do you have time for one or two more questions?
Yeah, sure.
We have a couple. So Dr. Richmond says, beautiful talk, Professor Rajan. Have the second hits been characterized for each of these conditions, i.e. the environmental exposures that tend to lead to loss of the other tumor suppressor?
Yeah, so really great question. And actually, I didn't touch on some other conditions like NF1 and TSE today, because I think they get a fair degree of coverage, but they're also important to have in that broader repertoire of conditions where the second hit's been characterized. But there's great work by like Tom Darling at the NIH that's, for example, looked at angiofibromas in the face of patients with TSE. And there, what is interesting is you get lots of C to T transitions or UV signature in the second hits in the cells in the skin, right? But when we looked at this in the sort of cylindroma patients, I touched right at the beginning about the fact that 40% of our tumors, 40% of our patients get pubic tumors at sun-protected sites. And so we started to look at SBS signatures, which help us kind of maybe sometimes, see, where the culprit might lie. And we were interested to see, for example, that in patients with cylindromas, like within the same patient, you could take tumors from the scalp and you would see a UV mutational signature there. And you would take pubic tumors and you wouldn't see a UV mutational signature there. And so there are some scenarios where, you're getting changes within a person and not all of it can be ascribed to the location or UV, for example. And I think what is interesting in these hair follicle tumors is that we think that the stem cells that are there are actually at quite a depth in the skin, such that photons of UV are unlikely to be what's driving the second hits. When you look at the mutational burden in those tumors as well, they are actually so low for skin tumors. It's sometimes hard to believe that these are benign skin tumors, but when you look at cancer sequencing projects, they've got, mutations which are tumors which are hypermutated and tumors which are, not particularly mutated. And these are tumors with a very low mutational burden. And so we don't think UV for cilled cutaneous syndrome is likely to be a big player. But that's, in that condition, but in other conditions, like say, TSE1, there is evidence to support that UV might be playing a role. So yeah, I think it's where the cells that are likely to drive the condition sit and whether they're in the range of photons of UV in the skin. But that's, based on research and hasn't, been something that we've been able to bear out in studies of patients in larger numbers.
And I think Sylvia Shen asks a similar question and says, thank you for the great talk. You mentioned differences due to genetic background a few times. Do you think there is a polygenic or oligogenic element to these diseases, or do you think there is strong environmental influences that affect the phenotype more, or both? I guess you've mentioned UV, but any...
Sure. So I mean, my view is that, it could be, as you say, oligo or polygenic changes that we're not yet in a position to define. I think one of the limitations of these models is, as provocative as they are to help us think about these questions, having the numbers we would need to convincingly show those, other changes, which up till now people hand wave and say, oh, modifying background genes and the like. We would love to be in a situation where we were better able to demonstrate those changes. But the challenges at the moment relate to the small numbers in those patients. But always interested to hear about, clever study designs or approaches that can help us discuss that. I will say something about digenic patterns, though. In some of the families that we've had exceptional presentations. So sometimes very young people with subcutaneous syndrome with metastatic cylindromas, for example. And recently, very sadly, we lost someone in a family who was 28 who had metastatic cylindroma from the scalp, right? And having reviewed the literature, back to 1842 when some of this was first described, we know that that's super young, and this is somewhere when we took the family history. What was really interesting was this finding that on the mother's side of the family, which is where all the cylindromas came, we had the genotype and everything else. But then as we dug deeper, we found that on the father's side of the family, there was a story of male breast cancer. And ultimately, the second gene that was impacting on the metastatic malignant phenotype turned out to be BRCA2. And so we had a patient in a BRCA2 family marrying another patient in a SILD family at that time, and then having children, some who had inherited two genes that drove the phenotype. And, these scenarios where two tumor suppressor genes are being brought together in certain families isn't as uncommon as people think. We've reported in the northeast of England families with NF1 and PATCH1 having children who have both got features of NF1 and nevoid basal cell carcinoma syndrome. And the list goes on. There are a number of digenic entities that we can start to point fingers at because they're quite penetrant in terms of the effect size of some of these variants. But when you're thinking about the modifiers in the broader context where the effect size will be lower, we need larger numbers of patients to help make the case there. And I think that is going to be a stumbling block.
Thank you so much. And in the interest of time, do you have any last pearls of wisdom for any trainees who are interested in studying rare genetic skin diseases, about how you got into this and how to approach funding, or anything?
Sure. No, and I think my personal view is, don't ever be put off by the sense of, oh, it's rare, or don't ever be put off about, oh, there's no funding, because there are always opportunities if you look for them. I think my experience has been one where I was really struck by some of these patients where you're sat, looking after a family. A lot of people have had their scalps removed. A lot of younger generations are there with tumors and thinking, what can you do for us, really? And we can talk about lasers, we can talk about skin surgery and the rest, but really what they want is, some like 21st century medicine to come their way. And I think we are in a really interesting time in terms of skin science, right? Because, what people used to be able to do even like 15 or 20 years ago, that would take a long time, say, even to sequence a person, we can do in an afternoon now. There are such amazing changes that have come forward in science in general. And as dermatologists, we have the ability, unlike many other physicians, to actually sample, affected and unaffected tissue and start to look for differences. So I think, the time is really interesting in terms of technology. There's a huge push from the patients in terms of advancing understanding understanding into how rare diseases happen and therapies. And I think if you bring together the energy around what the patients want to have, a good group of people who have an interest in trying to understand why diseases happen, funders are actually interested, and you can start asking questions and then building up from there. So don't be put off by how rare some things are, and in some ways you might find that actually there is a neat therapeutic that's there to help intervene. So yeah, an exciting time for rare disease.
Thank you so much, and thanks so much for your time today.
Pleasure. And thank you for inviting me to speak, and it's been a lot of fun. Have a good evening.
Bye.
Bye-bye.